Hello, my name is Jordana. I am a nurse practitioner in the geriatric and palliative care department at Phelps Hospital, and my aim today is to talk to you about the common issues I see when I work with families who have a loved one with a terminal illness and help make the process a little easier. Just as a disclaimer, this should not be viewed as medical advice. This is me just sharing my experiences. Anything I say should be discussed with the practitioner for the loved one that you are caring for, and it is not in any way affiliated with Phelps Hospital. I'm doing this completely on my own and, again, just sharing my experiences. So right off the bat, I'd like to just go over a few terms. I'm going to be using a lot of terms seemingly in a casual way, but they're not. I might use terms like death and terminal and dying very colloquially, but that's because they're a common part of my language. Just because I say them quickly or casually does not mean that I don't hold a lot of gravity to those words and know how meaningful they are. So just be aware that I am going to use those terms. Chronic illness is something that I define as an illness that someone may have for years and years and years that won't necessarily cause their death. Perhaps something like chronic pain. That's a good example of an illness that won't cause that person's death, but it's something that they live with. I say that in contrast to a terminal illness. A terminal illness is something that, again, may not last many, many years, but it is something that will cause that person's death. Many people think of stage 4 cancer as a terminal illness, but also dementia is a terminal illness. Someone may have them for a decade, but ultimately it's complications related to that dementia that cause that person to die. So again, a chronic illness is in my words, an illness that can last many years but doesn't end up causing someone's death, and a terminal illness is an illness that causes someone's death. So this relates to what is palliative care. Think of palliative care as a type of medicine, just like a cardiologist looks at the heart. Palliative care looks at the symptoms associated with a terminal illness. My job is to better that person's quality of life as they're dealing with treatment of that illness. So, like the definition says, relieving symptoms of an incurable condition alongside of conventional treatment options. We relieve those symptoms in terms of physical symptoms, emotional symptoms. We also look at family support, spiritual support, social support. So it really is an interdisciplinary effort to make someone's quality of life better when they are dealing with a terminal illness. I use this diagram here to explain the scope of palliative care. So if you think of this as any disease, let's say dementia again, on the left-hand side is the diagnosis, and on the right-hand side is death. Palliative care spans this whole illness from the beginning to the end. I might see someone with palliative care who was newly diagnosed, maybe just provide some social support, address any symptoms they might be having, and maybe we're not so involved here. But as they get closer to death, that's when palliative care typically gets very involved. But again, it spans the entire situation. And as I said before, we see people that are getting conventional treatment options. And I say that because oftentimes palliative care is confused with hospice care. Palliative care is not the same thing as hospice care. It encompasses it. So if we go back to this diagram, diagnosis, death, let's say this is dementia, hospice care is a very specific set of insurance benefits that takes place right there. Right when you have a limited prognosis. It has the same goal as palliative care, which is to better someone's quality of life, and it does that at the end of someone's life by giving them certain insurance benefits like more equipment, more medication, a visiting nurse. So palliative care happens this whole time, not just at the end. I want to explain palliative care's involvement in a terminal condition a little bit more, and to do this, I thought that I might give a case study, a typical case that we see. And again, I'm going to be talking about dementia. So something that we like to do when someone has a chronic illness like dementia is get involved early on. So this is a typical case. Let's say, as a background, when someone has dementia, typically toward the end of their life, we begin to see complications such as falls, urinary tract infections, pneumonia, and these are things that if we're involved early, we like to prepare families for. So let's say this man, Harold, he's 86, he has dementia. He hasn't really met with palliative care before. He hasn't really been prepared for the complications. His family has not been prepared for the complications of his illness. So let's say early in the year, he's hospitalized for pneumonia, gets antibiotics, does okay in the hospital, and goes straight to rehab. He's in rehab until March, let's say, and he does okay. He is walking around, he's regained some of his strength, but he does spend a lot of the time in bed, but let's say he gets back to almost the same level he was over here. He's discharged from rehab, he goes back home, let's say he's there for about a month, 2 months, and this happens again. Recurrent pneumonia is very common, like I said, at the end stages of dementia, so he's back in the hospital. This time, he doesn't do so well. Maybe he gets really confused, something that we call hospital-associated delirium. One of the complications of that is inattention, which can make swallowing very difficult and very dangerous for someone with dementia. It's very common for someone who develops delirium in the hospital to have feeding troubles. So the doctors say, do you want a feeding tube? We have to feed him somehow. And not knowing what else to do, the family say, okay. So he gets a feeding tube placed and goes to rehab. This time because now they need to learn to work with the feeding tube, and he's been bedbound for a couple of weeks. Typically we tell families that for every day in the hospital after a certain age, you need a week of rehab. So maybe, well, over here, he was walking with a walker. Now he's bedbound here. So goes to rehab with hopes of maybe gaining some strength back, but there we see even less improvement. He's more confused. He's not participating in rehab. Maybe he's only doing 30 minutes of rehab a day, and the rest of the time he's confused and bad. But let's say he's there for a month or so, goes back home. Unfortunately, he has aspiration pneumonia again. Many people don't realize this, but with the example of dementia, I'm just using it because it's a common one, you can also get pneumonia from the feeding tube. It's not a foolproof way to prevent pneumonia. This time, Harold gets pneumonia, and he's just so weak, so debilitated, so much weaker than he was over here, that he ends up on life support in the ICU, and unfortunately, this is how he dies. This is a case that we see a lot. Someone who is elderly, has the end stages of dementia, maybe over here in the beginning of the year wasn't necessarily end stages, but as we see these complications, as they don't recover from these hits, they get toward the end stages of dementia, and without someone guiding them, we tend to make decisions really quickly without thinking of the bigger picture. Palliative care hopes to keep the bigger picture at the forefront of our minds and help prevent complications and quite frankly, painful deaths. So let's look at Harold's case with palliative care involved. So let's say again in January, he's hospitalized for pneumonia just like he was in the previous case study. This time, because he's flagged on a list for being elderly, for having dementia, palliative care meets with him. And they sit down and they talk to the family and the next of kin, and they say, look, pneumonia is probably going to happen again. These are the options. We could do a feeding tube. This is why we don't recommend that. Frequent falls or complications, things that I mentioned before. While they're telling the family what to expect, they're also hearing a lot more about Harold and who he is as a person. How does he feel about his quality of life? Is he even able to report on his quality of life? Did he ever discuss advanced directives with his family? These are all things that play part of this conversation. After meeting with the family, they have a better understanding that it sort of, unfortunately, may go downhill from here. So they decided they don't want a feeding tube, they don't want to send him to rehab, they just want him to go home. So after that hospitalization, he goes home and he does home physical therapy and gets a home health aide. You know, in the last scenario, let's say Harold was able to walk with a walker from rehab, and this time he's chair-bound. He's not that strong, but he has an aide and he's still able to get around and do the things that he wants to do. May, just like the last scenario, this time Harold gets pneumonia again and he goes back to the hospital. Just like the last scenario, he develops delirium. Palliative care already has a relationship with his family. They sit down with him and they say, look, this happened again. We're part of that spiral. This is going to keep happening. The family then makes another decision to say, you know what, we don't want to bring him back to the hospital. We know that this is just Band-Aids putting on him to prolong his life. That's one direction this could have gone. For the purposes of a short time frame, sometimes families aren't ready to make that decision. Sometimes they say, we know this is just a Band-Aid, but we're not ready to let him go, or he still has some fight left in him. I use the term Band-Aid because that's a term that we apply a lot, where you see to someone who has a terminal illness at the end of life, complications frequently arise, and that's normal. But what we see is bringing them back to the hospital may fix a little problem, but it doesn't fix a bigger problem. In situations like we are here with Harold, that's a time when we say, look, this is likely to recur. This person is spending more time in the hospital than they are at home, and they're not getting better. So for the reasons I just said, let's say the family decides at this point they don't want to bring him back to the hospital, and because he is at the end stage of his illness, now he qualifies for hospice benefits. So he's discharged home with hospice, and a couple months later, he ultimately dies of pneumonia, the same way he died in the other scenario. But this time it's at home with his symptom managed, surrounded by his family. Maybe he even had some ice cream before. So ultimately, Harold died of the same cause in both scenarios, but they were very different scenarios. One was in an ICU on life support, and one was at home because the family had been prepared of what to expect. Very common case that we see in a variety of illnesses. We could see this with congestive heart failure, with different cancers, where people tend to make spur-of-the-moment decisions without thinking about someone's overall quality of life. In this particular instance, I'm really talking about palliative care in the guidance sense. I would say 50% of my job is managing someone's symptoms, and 50% of my job is guiding families on what to do next. This example really focused on guiding families through the decision-making process. Equally as often in the hospital or in our outpatient clinic, we're seeing patients that thankfully are not as sick as Harold and maybe are just living with a terminal illness but don't need to be hospitalized. And that's when we manage their symptoms and sort of have these conversations earlier so that we don't have to have them in the hospital. So yeah, keep going from here. I want to jump into frequently asked questions about palliative care. In this section, it's going to encompass the forms that you need to fill out, how you get more help at home, who's appropriate for palliative care, like this question asks, and really more details about hospice care. So who is appropriate for palliative care, and how do I know if it's too early? So anybody with a terminal condition is appropriate for palliative care at any stage. Common terminal conditions that we see are cancers at later stages, dementia, Parkinson's, congestive heart failure, end-stage kidney disease, maybe victims of strokes. Any condition that is ultimately going to cause that person's death is something that we can help with. If you're not sure if it's a chronic condition or a terminal illness, you can always just call. You don't need a referral unless your insurance requires it, but there's nothing stopping you from calling our office or any palliative care office and just seeing if that person would be appropriate for palliative care. It's also never too early. We hear that a lot. Is it really time for palliative care? As you saw from the very first slide, we can see someone the entire time. We just might not be so involved in the beginning. Maybe we provide that emotional support. We recommend support groups. We check in to see if they're symptomatic at all. And maybe we see them every few months or every 6 months. Toward the end is really where we get more involved and more active and take over more of the care. But like I said, it's never too early. And even if you're not sure, you can always just reach out to your local department and ask. How do I get more help at home? This is a big question. Unfortunately, and this opinion is just mine, our healthcare system is not very conducive to staying at home and living out your life with a home health aide unless you can afford it privately, and that's sort of just the sad reality of it. What we find is there's 3 ways you can get help at home. One, it's Medicare, Medicaid with a D, and private. So if you have straight Medicare, and I should preface this with, I'm not a social worker. This is what a social worker is really an expert in. I'm just sharing my experience as a healthcare provider, as a practitioner, and what I see my patients go through. Certainly not the most skilled in this, just sharing my experiences. So if someone just has straight Medicare, which is when you're eligible once you turn a certain age, it's very difficult to just have that alone and get any sort of help. The help that they will cover is what we call for a skilled need. If that person fell, if they have a new medication, if they have a wound, if, I don't know, they have a new diagnosis, these are things that Medicare will cover for a short period of time. It always expires. It's a couple of weeks. In terms of a visiting nurse, a home health aide, maybe PT, it does not last long. Medicaid is a longer term solution. That once you're evaluated, and with Medicaid, there's 2 types, either institutional or community. Institutional meaning in a nursing home, or community at home. But as many of you may know, getting on Medicaid is not so simple. It involves getting an elder care attorney involved to see if what it takes to get onto Medicaid makes the most sense for your family. It is needs-based, and for some families, what it would take to get on Medicaid is not in their financial best interest. So my advice is, if you're considering Medicaid for your loved one, you must meet with an elder care attorney, or you should meet with one prior to thinking about it, so that they can guide you again by looking at your financial situation as a whole and seeing if it's the right thing to do. It does take a couple months to get all set up with Medicaid. It is not a quick process, and there's a 5-year look back, I believe. So it is complicated. I would say if you have it, and once you have it, it does make things a lot easier. You can get an aid much easier than if you just have straight Medicare. And like I said, that aid doesn't really expire in my experience. It doesn't necessarily mean you're going to get someone 24 hours, but they do give you someone, whereas Medicare really doesn't long term. So if you have Medicaid, that's certainly the best situation in terms of guaranteeing that you're going to have some help, but it's not so easy and may not make sense for you just to get onto Medicaid. The last category is private help, and to be honest, this is what most of my families end up doing. Either they do a 24-hour private home health aide, or if that's not financially feasible, which it's not for a lot of people, then they alternate, having family members or close friends help in addition to a home health aide. You can get a private health aide through an agency or through word of mouth. I would say most of my patients don't need like a registered nurse to take care of them. They really just need an able-bodied person who can help keep them clean and dignified and move around. You don't necessarily even need to be certified for that. Of course, having certification does come with benefits. If you use an agency, they're insured. There's obviously benefits with that. They might be a little bit more expensive. But again, you can also just find someone word of mouth. And this is where long-term care insurance kicks in. If you paid for that, or if your loved one paid for that early on, typically they'll cover insured agencies. Though I think that there is a deductible or a waiting period, you have to really know your plan. But this all falls under the category of a private home health aide. Again, just to sum it up, I would say most of my patients end up using a private home health aide for either a portion of the day, if not the whole day. The rates vary if you're doing a couple hours or 24 hours. Medicare itself really does not provide you with much except for short-term help, and Medicaid does provide you with longer-term help, but it might not make financial sense for you to get it. Okay, what form should I fill out? This is an important question. Most people have this, a living will. I used a template when I was creating this PowerPoint, and this was the slide that had everybody in the company's picture. And I thought I could still keep the job descriptions because it really does apply for the three main forms that we see. So, most people have a living will. This is something that they filled out with their lawyer years ago. They probably forget what's in it. It's in a drawer somewhere. They have to go find it. And they all say the same thing, which is if there's no reasonable hope of recovery, I direct my healthcare agent to let me go, essentially. I don't think I've ever seen anyone that doesn't have that language, all variations of that language. The problem with living wills is they're just guidance. They're not medical orders. Sometimes patients are in the hospital and I say, do you have any advance directives? They say, well, I have a living will, I did it years ago, blah, blah, blah. Don't you have that? We don't have anything that's not giving to us in the hospital, but even if we do have your living will, that doesn't mean anything. It is not in order. It is just guidance for your healthcare proxy to then make a decision for you. Well, what's a healthcare proxy? A healthcare proxy is the person who is making medical decisions for you only if you are not able to. You can designate more than one person, though it has to be in an order. You can't designate all your children at once. You designate one person, and then if they're unavailable or if they defer, there can be a second one. That's the healthcare proxy. So if you're just looking at these two, the healthcare proxy and the living will, the healthcare proxy would be using the guidance of the living will to make a decision for you on your behalf. The problem is that most people who fill out a living will just do a standard one. It's not properly explained, and they never really talk to their proxy about what's important to them. In comes the MOLST form. The MOLST form is a medical order. It is signed by a healthcare professional like a nurse practitioner or a physician, and it is an order that it needs to be followed. If you have a MOLST form, it's bright pink so you don't lose it, and I'm going to go over the contents of it, but if you have it and you come to the hospital with it, it cannot be disputed. This is where someone says, I have a MOLST form, I'm DNR, there's no questions, it is a medical order. Whereas if someone comes in and says, I have a living will, well, that just kind of says, if things look bad, I don't want to be kept alive. It's vague. It's situation dependent. And again, it depends on the healthcare proxy to make that call. The MOLST is totally clear. It is not situation dependent. It is one decision going forward that applies for everything. And it talks about resuscitation, feeding tubes. I'll go over them. The reason for these titles, the MOLST is the CEO. There's no disputing it, and it's crystal clear. Then we look at these two titles. The living will, it has opinions, but they don't really hold a lot of weight because they're just not as embedded as the MOLST form is. You could think of the healthcare proxy as the chairman of the board because it can somewhat influence the person who's in charge, the person who's writing the MOLST, but really they only should come in when that person is incapacitated. So again, the MOLST is the most important document. It cannot be disputed. Healthcare proxy is second most important. This is if the most hasn't been filled out, this is the person making decisions for the patient if they are unable to. And the living will is a document that many people fill out many years in advance, and it just provides general guidance for the healthcare proxy to then make a decision. So we're going to look at the most form a little bit more. What I want to preface this with is the most form is a lot. It is overwhelming. It goes through things like CPR and life support and a feeding tube and dialysis, and do you want to go back to the hospital, and do you want fluids? If I can have you walk away with one important thing, is that this form is only appropriate if you have a life-limiting diagnosis for a prognosis of 1 to 2 years. This is not appropriate if you are 40 years old or 50 years old or 60 years old and just have a history of high cholesterol. The reason for this is all of these interventions here, they are painful and they are terrible and nobody wants them, but they exist for a reason. The horror of CPR, broken bones, and bloodiness, maybe even brain damage. These are not going to help someone who has a prognosis of 1 year to live, but they will help someone that's young and healthy. If you get into a terrible car accident, you meaning a healthy person listening to this podcast, and you need CPR, and they break your ribs, and you need dialysis because your kidneys failed, that is going to be horrendous, but you will probably be fine. You will get through it. You will go to rehab. It's going to be a long journey, but you will be okay. You won't be okay if you only have a year to live with a terminal condition. That is when all of these conditions start to become more burdensome than helpful. That is why this form is not appropriate if you don't have a terminal illness, because how could you know? You could say CPR sounds painful, I don't want it, and that's true, but there are so many factors that go into that, and these are all interventions that will help you most of the time in the long run. But again, we know based on data, based on case studies, that these interventions don't do much to protect someone's quality of life at the end of life. Maybe they extend it for a little bit of time, but they don't promote good quality of life when you are at this time frame, for the most part. And that is why the most form exists. For people that know that they have a limited amount of time, 1, 2, 3 years, that is when we give them the option of choosing to say, I do not want these interventions. I don't want to go through that suffering if it's not going to benefit me in the long run. So this form you can find online. It must be filled out with a healthcare provider for 2 reasons. 1, a healthcare provider needs to sign it, but 2, they really need to determine how each of these conditions relate to your particular illness. For instance, if you have kidney failure, then the question of dialysis is far more pertinent than if you have dementia, where with dementia, the feeding tube is probably going to be the most important. So you must fill this out with a healthcare provider because they have to sign it, but also because they should guide you as to what makes the most sense, keeping in mind that patient's values. Front and back, you can find this form online. The one thing that I also just want to briefly talk about is CPR and life support. It's very hard to give sort of a spiel without knowing everybody's own or everybody's conditions that have a terminal illness, but CPR is not what you see on TV. Nobody gets up from CPR and opens their eyes and suddenly takes a deep breath. When you have CPR, typically, not all the time, but the way I describe it to families is CPR is necessary when your heart stops, and when you're in the hospital, typically the majority of the time it doesn't come out of nowhere. It's not suddenly like you have a heart attack. It's typically that person is in the hospital, and despite everything we're doing to get them better, they're just not getting better, and their body is trying to let go. That is when the question of CPR and life support come into play. The way I think about it is it's almost a protective measure to think about not resuscitating someone and not doing CPR. When they are at the end of their life, that is when these interventions can become more burdensome. In medicine, we always try to balance benefits and burdens. And CPR, when you're pounding on someone's chest, you're breaking their ribs, you are putting them on life support. Like I said, it can cause brain damage, it can cause a collapsed lung, it can cause a drop in blood pressure, shock. These are things that can very much be harmful to someone who doesn't have a long time to live and who doesn't have the recovery potential. CPR and life support take a lot to get through, and if you're young and you're healthy, it is doable to get over them. But as you have what we call comorbid conditions, many chronic conditions, advanced age, cancer, dementia, all the conditions that I listed before, your likelihood of having a good recovery from CPR and life support is very low. And you really have to have a good, what we call functional status, meaning are you walking around? That's a good functional status versus being bedbound. The person who's walking around and independent, even if they're 90 years old, is going to have a better recovery than the 60-year-old who's bedbound and can't walk with a chronic disease. So that is why you have to discuss this with a healthcare professional, because it is so individualized. But I did want to speak to the concept of CPR and life support because it comes up. And I would say the major takeaway is if you're young and you're healthy, your likelihood of getting through it is far greater than if you have multiple comorbid conditions and have what we call a low functional status. But again, take what I'm saying, talk about it with a healthcare professional who knows the individual situation. We're going to move on to some talking points, and then I'm going to briefly discuss hospice, and then I think we are done. So, how do I find out my loved one's wishes? How do I have that conversation? Do's and don'ts. Don't. Just ask them. This is what we see a lot. Families are well-meaning, just say, if your heart stops, do you want me to bring you back? Do you want CPR? These are questions that you really need to hear that whole spiel that I just gave in order to answer. We also see a lot of people ask their loved ones in the hospital what they want done. The statistic, I'm guessing this number, I can't remember what it is, but something like 80% of people don't remember being in the intensive care unit because it causes so much confusion. People don't know what day it is, they don't know if it's day or night, there's alarm ringing, they're not getting good sleep. Most people don't recall being there. So in order to weigh into this condition of do you want CPR, what are your wishes at the end of life, you have to really be able to engage in this conversation. You have to know what their prognosis is. You have to be able to know how their condition is affecting their body. And if your loved one has memory impairment, or maybe they just don't have insight into their condition, they might not be able to engage in these conversations and weigh if CPR, knowing what I just said, is right for them. So the worst thing you can do, in my experience, is just straight up ask, do you want CPR? There's so many things you need to know before then, like do they understand how sick they are, and do they understand what CPR is? I encourage families to not directly ask, and instead ask the bigger questions. What brings you joy? What quality of life do you want, and what is important to you? What quality of life would be unacceptable to you, and what does good quality mean to you? The reason I invite families to have this sort of broader conversation is because the specifics of is CPR right for them, is a feeding tube right for them, that is something that your healthcare professional can then recommend based on your loved one's answers to these questions. For instance, maybe if what brings this person joy is just being able to engage with family and see their grandchildren, well, maybe if they have a condition that inhibits their ability to swallow, but they're still walking around and they still can have meaningful time, Maybe a feeding tube is right for them because they can have some more time with their family. But maybe your loved one, you know that they're strong and they're independent and they would hate to depend on an aid. Maybe what is unacceptable for them is to need to have an aid, or to not be able to bathe themselves, or to lose control of their bowels. If that is where they draw the line, then maybe a feeding tube wouldn't be appropriate for them because maybe they don't want their life prolonged. So what is far more important in my view is knowing what is of value to that person, knowing what type of person they are. These will help us in the palliative care team, even just a primary care physician, anybody who knows that patient, knowing these traits about them and what's important to them will then help us guide you into what would be the best decision for them. Let's say you can't ask them questions. Ask yourself. Think about the person you've known for so many years. What do they love? What type of person are they? Sometimes you don't need to ask them directly. You can just think back to your childhood as to who this person really is. Okay, how do you deal with a person who is resistant to change or help but needs it? I'm going to group into this. How do you kind of split help or get some help from siblings or people from out of town, so that you're not the only one doing everything? I'm going to group these two things together. A couple of things. So the first thing that I would suggest is utilize that person's primary care physician if they have one. You don't want to be the bad guy if you don't have to. And as healthcare providers, we're happy to be the bad guy if that means keeping the safety of our patients first. It is refreshing and comforting when I get calls from family members that say, hey, you know what? I know that you just saw Dad and he looked great, but it took him 6 hours to get ready. And he was totally confused, but he came off like he wasn't. And maybe I didn't pick up on that. Maybe he answered every question appropriately because he had been practicing. It happens. It is so helpful when families can call us with their concerns or insight that may not be apparent from the visits that we saw. So team up with that person's primary care physician if they have one. It is not violating HIPAA. It would be if that practitioner then said things to you that they weren't given permission to, but simply to listen to concerns is completely okay. If you are speaking to your loved one directly, come from a place of caring and not accusation. Use observations. Don't say, use observations, meaning I saw that the car had a dent in it. Let them fill in the story if they can. But don't accuse them of being unsafe. Don't accuse them of even doing things intentionally, because they're probably not. Coming from a place of concern is really, really important. Compromise and pick battles. And this goes with the next one, safety first. What I find helpful is to have patients and family members make a list of all the things that they feel that they need to get done. I'm stealing this line from the suggested podcast below, which you definitely should listen to if this slide speaks to you. Do a C+ effort when you make this list. So think about everything that you need to get done, and then think about the bare minimum that you can do right now. If you try to get everything done on this list that you just made, you will go crazy. And depending on how severe that person's condition is, you might be dealing with this for many, many years. Make a list, pick the safety concerns first. How can you reduce falls? How can this person eat safely? Doesn't need to be healthy, but how can they eat? Who's going to keep them clean? The basic things that you need to get done. Compromise and pick your battles. If taking away the car is the most important thing and you feel that they can live alone for a little longer without a home health aide, take away the car. It's better, because we always want to preserve your relationship with your family member. Again, this is the time to team up with a physician, but if you got to do it, Safety first. This is also when getting in people from out of state or family members that aren't so involved, this is when you can collaborate. Typically what I see is there's one child, if we're talking about a parent, one child who handles the financials and one child who handles the medical stuff. And that works for a lot of people. But if that doesn't work, share this list of the bare bones things that needs to be done. Have them decide what they feel comfortable doing. Maybe this person is comfortable contributing in terms of food preparation, but they're not comfortable bathing someone. Having an open dialogue that is so important in any type of relationship that we have is super important here, but also knowing what people's boundaries are. And lastly, join a caregiver support group. We have one at Phelps. There are many online. I can't tell you how many people say I don't need to talk to anybody, but then talk to me for 45 minutes. And it's because I understand, because I deal with this a lot. But talking to people who are in your exact shoes or close to it can be so helpful, even just to vent. Most people don't know the right thing to say in any sort of tragic situation, and you can speak to a group of people that do, and maybe you can get some tips from them. I really can't recommend caregiver support groups enough. I know it's just another thing to add to your to-do list, but it can be really, really helpful. Lastly, these are great podcasts. The Integrative Palliative podcast is meant for healthcare professionals, but there are so many that are tailored to that can be heard just by patients and their families. Listen to these two. These are super, super helpful. What is hospice? Okay, so as I said before, palliative care is a type of medicine that tries to improve someone's quality of life at any stage of that illness. Hospice is simply a set of insurance benefits someone gets at the end stages of that illness, specifically 6 months or less prognosis. Now, you might outlive hospice, or your loved one might. That happens. Many times people are discharged from hospice. That's okay. There's no financial penalty. It happens. But you need to have a textbook prognosis of 6 months or less in order to qualify and not be getting any sort of life-prolonging treatment, like chemotherapy. So there's two types of hospice scenarios. There's inpatient hospice and community hospice. Inpatient hospice is what you think about when you heard Uncle Joe went to hospice. It takes place in either a hospital or a hospice facility, a freestanding hospice facility. Community hospice is what the majority of people on hospice are on. It takes place at home or in a nursing home. The reason why most people are on community hospice is two reasons. One is most of the time when you're dying peacefully. Inpatient hospice is expensive. It really does come down to finances. Hospice is a program that is covered typically by Medicare. And if you think about it, being in these facilities with 24-hour nursing is expensive, probably many thousands of dollars a day. Most people, when they are dying, either have minimal or perhaps even a moderate amount of symptoms, but they are able to be helped by oral medications and at-home nursing care. So the majority of hospice is delivered in what we call the community setting, either at home or a nursing home or an assisted living. So what are the major differences? Inpatient hospice, again, if we're going with it's expensive and only a certain number of people get it, these are for people who really only have high symptom needs. This is the person whose nurse is in the room every 30 minutes pushing pain medicine through their IV. This is not someone who is, just sleeping a lot. Maybe that person needs a lot of care, but they're comfortable. So inpatient hospice really just looks at symptoms and prognosis. If someone we think is going to die within hours to days, they will likely, not guaranteed, but they have a better shot of qualifying. But at its core, inpatient hospice really is just for people with what we call a high symptom burden, whose symptoms are so severe that they can't be cared for at home. It is 100% free. It's covered. There's 24-hour nursing care because it's in a hospital, but it is only short term. Sometimes we have people that have this high symptom burden, and then they go to inpatient hospice and we fix their symptoms, and then they go home on community hospice. This is not a long-term program. Community hospice is hospice at home, like I said, or in a nursing home, but let's stick with home hospice because that's the most common. The equipment is covered, the medications are covered, a weekly nursing visit is covered, but what's not covered is someone to take care of that person. Then we're back to the scenario with the 3 options of how you get help at home. They will send an aide, but it's very minimal, maybe a couple hours a week. It's the family or private caregiver is the one who's delivering care in community hospice. The reason why it works is because they have a 24-hour on-call network to guide you. So let's say that nurse visited on a Monday and this person was dying but comfortable. And let's say Monday night at 2 o'clock in the morning, they look uncomfortable and you don't know what to do because you're not a nurse. You can then call hospice. They'll tell you what to do over the phone, or they'll send a nurse out that right then and there, or perhaps that morning, and guide you through what to do. But community hospice really is driven by the family. Why is hospice necessary? Think about it this way. If you knew you had to die, you are given the option of how you would like it to be. This is what dying in the ICU can at times look like. Limited visitors, lots of machines. No, not every situation looks like this, but it can if you get hospice involved early enough. Most people would choose this. Having a peaceful death in today's, how do I say this, culture of heroic medicine, it involves being intentional. If we go back to that scenario about Harold, it took intention and planning to not get to this point. It took 2 meetings with the palliative care team to have a death like this. If we don't say anything, if we don't advocate for ourselves, we live in a society of heroic medicine, which is amazing for a lot of things, but as you get to the end stages of a terminal illness, this doesn't help so much. Hospice is necessary because it prevents this by keeping the person at home and taking care of them there. Hospice affords the opportunity to avoid hospital readmission by having that nurse come frequently, manage symptoms at home, obtain the needed medical equipment. As you get to the end stages of an illness, you need more help. You need a wheelchair, a geri chair, whatever. Hospice typically will cover all of it. But you also need social and spiritual support, and so does your family. And that is what hospice is great at. And you have a place to call 24 hours, because if you don't have hospice, then you're just calling 911. This is the last question. It's a very specific question because someone submitted it. Where do patients die in Putnam or Westchester County? Most people die in community hospice at home. But the other options for inpatient hospice care, if it's short-term, like we spoke about, that can be at any hospital. If it's like what I call midterm, maybe days to weeks, there's regional hospice in Danbury, which is technically an inpatient facility. But again, that's really for only a couple weeks maximum. If we're talking about longer term, which is probably what this person is getting at, there's 3 options. Calvary in the Bronx, which is a very unique hospice type hospital. It's a wonderful place. It's one of a kind. And that's really for complicated, complex patients that are dying. They likely will not accept someone that is just kind of, like I said, laying there peacefully. They are really for more complicated patients. Nursing homes and getting into them for long-term care typically requires Medicaid with a D, but sometimes Sometimes you can go for rehab and then long-term care that, is it individualized. Or Rosary Hill. Rosary Hill is a beautiful place in Hawthorne. It is for as long as you need it. Technically, it is a community hospice. It is 100% free. It is round-the-clock care, but it is only for patients with cancer, and it is needs-based. So a good candidate for Rosary Hill has low financial means and has cancer, and the application process does take a while. This is not an immediate answer. Typically, it takes days or weeks to get an answer, and they may not have a bed available. But if you plan well enough and you have cancer, Rosary Hill can be a beautiful place to end your life. Okay, that is everything. So thank you so much for listening. I'm sorry for the interruptions. I hope this gave you some general points on important things to know when you're caring for a loved one with a terminal illness. I'm happy to answer any other questions that you have. You can email me at palliativenpjordy@gmail.com. Any questions, please feel free to reach out, and thank you so much for listening.